Good afternoon, ladies and gentlemen. It's my honor to be here again talking about the hidden population which are drug users and some injecting drug users. I myself are not using any illicit drugs. I have to say that. But maybe because I do research and have working relationship with Ozone Foundation, PSI, who are the NGO working with people who inject drugs for a long time in Thailand. So we work together and learn along. Thailand may not be the perfect country that can organize service delivery to people who inject drugs and people who use drugs, but we are trying. So in this region, there may be some other countries that trying along the same line, and some may do better than Thailand, and some we may be able to get access better, and we can learn along. So I'm happy at the end to share experience and so on. So my talk would be rather a broad view on how we look at the service and how best the service that be effective to solve the drug problems. And then I will go further on the treatment cascade on reach, recruit, test, treat, retain. And for the substance use disorder, we add the word recovery as the target that we always added for the effective drug treatment. I may be the first person to try the multiple choice question here, just to test whether you understand a little bit about addiction. Which of the following is the best description of addictions? A, B, C. How we can do a poll here? Would you suggest raise your hands, or do you have a clicker? No? Okay.
Okay, I guess we can do it.
Yeah, put your answer. Which of the following is the best description of addiction? I think you have only 6 can successfully reach and send in the answer. And 4 out of 6 got the right answer. Congratulations on that. So addiction is a disease that caused by not C. I'm sorry. 2 out of 6 get the right answer. It's a chronic relapsing brain disease because addiction has many mechanisms, neurobiological mechanism in the brain, and it's a basis for their repeated behavior. And now the WHO accept that addiction is a chronic relapsing brain disease. So not actually caused by the substance itself, it has more complex mechanism for addiction. But thank you very much for these 6 people. I don't have a prize for all of you. I'm sorry. Maybe the other has. The people use substance in various reasons. There are many types of substance use. Some use as experimental. Most of them are teenagers, use it occasionally with their friends and so on. And when they get a good sense of things out of their substance use, they remember that, their brain remember that, and whenever they want to get that good things, they will searching for that substance, for recreational, for work, for things. So that become a habit, and some may go on further to become a regular user. And sometimes they may use it heavily and get affected, and sometimes they use it regular enough to become dependent on the substance. So that's a pattern of the addictions. Focus on the substance use here. There are two key indicators for drug dependence that we know well. I think one would be tolerance. The nature of people who use substance regularly, they need to use more and more to get the same result. And when they use it regularly enough, whenever they don't have substance to use or they stop using it abruptly, they will suffer from some withdrawal symptoms. So that's two main indicators of drug dependence. But actually, international classification of disease provided more detailed classification and diagnostic criteria for drug dependence. And one of the major issues that people not quite recognize would be polydrug users, not uncommon. That means when you find one person who uses one substance, keep in mind that they are not using just this substance. They may use this substance today, but tomorrow they may use another substance. So you need to keep in mind that you have to explore and see whether the clients that you encounter actually using only one or more than one substance. And as the world grows, actually, substance that's available through internet, through friends and various things, grow beyond the legal limit. Now we have a teenager try to use a prescribed medicine in a wrong way, abuse them, and try to use the side effect of medicine like benzodiazepine or painkillers to enjoy and to gain access to their friends and creation and get harmed from that. So roughly globally, there are about 5% of population use drugs. In Thailand, we do national household survey and we get a similar result. About 5%, not all of them, depends on substance that they use. Only about 10% among these drug users that will have drug dependence conditions. So when you find your clients using drugs, your clients may be sex worker, your clients may be MSM, maybe the others, and found out that they also use drugs. Don't try to jump over that they get addicted to substance. Only 10% of all substance use would go and then get dependent status. So not all of them need medical attention in terms of drug treatment. Among these, obviously, there are many who inject drugs. The estimation globally would be more than 12 million people still using drug through injection. And we all know that HIV, hepatitis B and C is the main burden for this population of people who inject drugs. But keep in mind that although this is HIV medicine symposiums, but your patient who get HIV infection from drug injection may get more than HIV. And actually we learn along that people who get HIV infected already would have high prevalence of hepatitis C infection as well. So you may need to look at the other health problem among this population as well. So apart from hepatitis C, actually there are many other chronic disease from the substance use, which should also include alcohol and tobacco as well, keep in mind. UN, ODC and WHO actually agree upon the best way to handle drug problems. This is the model of community-based service that proved to be effective in terms of get access to accessibility, the quality, and also the recruitment, retention, and also recovery back to societies. So I think it applies to most of chronic disease that we need to base our service near community. If it owned by the community like MSM or TG, their community organize their own service. That would be the perfect strategies. It's safe and it's cost effective as well. Principle, when you find your clients taking drugs and you would like to extend your care or service for these drug users, there are 12 principles that we need to take care along this line. The first one is any way that you can recruit them into the service is good enough. There are many evidence that either recruited by police into the service or recruited by the community or walk in or by their friend referred to the service. If we have a proper service that understand the nature of disease and have retain them in the service long enough, then the result is getting better and better. So the first principle would be no wrong door. They may come to TG clinic with drug problem as well. If the clinic handle them properly and then refer to the proper service and can retain them either in TG clinic or at the other client-friendly clinic, that also be benefit and can reduce harm and other problems and gain effective outcome at the end. So it can be community-based, it can be hospital-based, it can be drop-in center, it can be health centers in the community. The second important principle would be try to reduce stigma and discrimination. This is quite difficult to get in general because there are two types of stigmatization. We stigmatize them and they also stigmatize themselves. So with this double stigmatization, it's very difficult for one drug user to be able to walk in any service and then asking for help. We need to reduce this by providing a low threshold similar to MSM and TG. But because drug use is considered to be illicit behavior in many countries, in most countries, so police chasing them around and they risk their life actually to be arrested. Once you are arrested and put in jail, actually it adds even more stigmatization, decriminalization, and it ruins their life. After they get out from the jail, it's very difficult for them to get into the community and have friends and work and look after their family as normal. So that's very, very important to make the place, the service, very safe and friendly for them. And as TG women demonstrate that if they organize their own service, they know how to communicate with their communities. In Thailand, Ozone Foundation is the drug user organization that try to deliver harm reduction services to people who inject drug in Thailand. So they know how to communicate to their friends and how to get access to them, how to provide a service that's friendly to them, and how to convince their friends to be retained in the service and get more and more services. So if we can achieve that, especially if we can organize that close to the community, we can improve accessibility, and if affordability is also there, for example, they don't need to pay out the pocket, that would be better as well. There are many people who inject drugs that still working in the community. People in the community in rural area, actually they know how many people inject drugs in the communities. And if they are friends, they have good relationship, and people who use drugs, actually they contribute to the community work, they're still looking after their family properly, but they still use drugs. I think they have another status when compared to people who use drugs but keep on using drugs all day long and do no work and have no income and so on. So if we can allow them to enter into their own society, be at home, minimal disruption of their social link, their family link, and try to keep them there while we're working with them on how we can help them in terms of health and social services. That would be the best principle. By doing so, then that means we ourselves, just one service, may not be able to solve all problems around drug users. We need to integrate our service and link it to the other existing services. It may be medical services, refer them to the hospital. It may be vocational services within the communities. It can be also legal service in the communities. In Thailand, we are trying to provide legal service at the community level with limited resources. We do have trained a lot of community justice volunteer around the countries, and they can provide legal service at the community level. So if we do have this existing service, we can sort of integrate it and then can keep the drug user in the community while we also engage them into our service. So if we can keep them there at the community, we can use community resources. The word community here may be the general community in the rural area, or maybe TG community. If you find that your clients use drugs, you can keep them in TG community as a member of TG community, but also link them to the other services, and you can utilize the resource within the community to provide social service for them, whatever you can. In this way, then they becoming a part of the community, a part of the social society, and they would be able to gradually recover and be part of active member of the society. So participation of them into the service, into the treatment is crucial. It's similar to MSM and TG, that if you have them, allow them to participate in planning how to solve the problem around them together, including their family, and obviously if they have a clear community that they belong to, then we can develop a treatment and relevant target that fit to that individual drug users, and that would make them happy to maintain in the service and gradually recover from that problem. Each client would have different needs, and when you look at the life of one drug user, actually they have so many needs, some even basic needs like the shelter, for example. So if you can organize some short-term shelter for them, that would be the essential step to do so. When they have a proper basic needs response to them, then they are able to engage into the service and be recovered. Normally, in general, they would be able to engage in NGO or their peer service. But when their peer service refer them to hospital or the other service, it's quite difficult for them to engage or get access to the other service because of the stigmatization, because of the problems, and because of the police who chasing them around as well. So it's challenging to deliver a proper service, which is health and social service that they needed to any one drug user without the proper policy environment, proper understanding of the services around them. So you can see that it needs to oriented the related service around them. It may be impossible task, but if you start from one service to the other service according to the priority of the service needed, then I think gradually people would learn along, and when the outcome is getting better, for example, a client in the methadone maintenance clinic actually has a very good outcome, and when the community see the positive trend come out from the service, then they're happy to come in and work with drug user and their families to speed up the recovery. Yes, close collaboration between the sector in terms of helping to solve misunderstandings, helping to solve about the proper referral procedure or whatever that can be helpful and needed, especially when it is in the urban setting. There are many steps to integrate various services around drug user. But in community setting, in rural area, in Thailand, we have district hospital, we have health centers that work together, and we have many village health volunteers that working as a team. So they actually know each other with various sectors. They know police, they know the interior, they know the village leader. So they in the rural area in Thailand, we found that it's easier for us to organize the community-based service for people who use drugs, because we can collaborate with many sectors better based on the existing understanding and relationship within the community. And obviously, if they come to methadone program and they get only detox program, which is not effective, once when you turn detox program to be methadone maintenance program, according to the evidence-based guideline, the number of clients will increasing. We witness this in many areas, and I think in the other countries as well. So actually if we provide a service that responds directly to their needs, they will come. Not just they need the peer to recruit them to come. If they come and they find out that the service that delivered to them are not friendly and not effective, they won't come back again. So that is also the essential issues. And we need to also respect them, the informed consent process, to respect the voluntary participation into the treatment would need to be take care to respect their human rights as well in various issues around this human rights issue. The last principle would be something that people who first would love to help drug user to engage into any service. Hopefully, they would love this drug user to be abstinent from drugs. And they become dissatisfied later when they find that this drug user, after 2 or 3 months in the service, they get back to drug use again. Actually, if you understand that it is a chronic relapsing brain disease, you will be expecting that relapse is something that you will find, as always, in the process of drug treatment. However, they relapse through drug use once, it doesn't mean that they relapse back to the previous behavior. Actually, someone probably want to take something as a separation, so they take whatever they satisfy, so they relapse to drug use. But if we take that as a learning experience and still retain them into the system, that can be the learning experience for the drug user and the healthcare provider on how to better help this drug user to be less and less relapse and recover better and better. So when you find them relapse again, don't throw them away. Please still keep them into the practice and take that relapse as a learning process for you both, and then see how we can manage the relapse next time better. So that's various components. If we want to have an effective service for drug user, we need community organization, NGOs, we need primary health services, and we need social services for these drug users to be able to engage into normal life as a normal society member. There are many examples in Asia that try to use principle of community-based treatment models like this to reach out to people who use drugs and successfully retain them into the system based on voluntary basis, client center, and has involvement people who use drugs and civil society into the treatment process, and add on comprehensive health and psychosocial care services. My second question, I hope more than 6. Who will be the best one in delivering services for drug users? I have 4 choices. First one is health worker. We got 1. B is police. We got nil. Actually, good police can lead to a better service as well if they understand, because they are the one who meet drug user easily. They know every drug user in their area. But anyway, you don't trust police, right? peers, obviously, we learn from MSM, we learn from TG that peer is the best one that can reach out to their friends and deliver the service. Family, community members, yes, actually family is the last one who know or learn about drug use of their family members. Why their friends, their neighbor inform them about their sons using drugs. They never believe that. They never believe that until the school called them up and have a meeting with them on drug use of their kids in the school and so on. So actually, the best one, probably the right one here, 8 of answer. But my point would be, actually, if you can use all, remember the first principle, no wrong door. If you can communicate properly with the police, and when you compare the police job, if they find drug user, they have to arrest them, they have to test urine, they have to write up the history, they have to investigation, they have to proceed this case to the justice process. When you compare to when these police intercept drug users, they have a friendly chatting with drug user and they offer treatment services. For the police, the second choice, provide them less burden, actually. Less burden. In this country, we have seen many drug users arrested and put in jail a lot. That's more than enough. More than enough. So our police, many police actually fed up with that as well, because they thought after a while the problem in the society, drug problem, should reduce by their job because they keep on arresting. But actually it turned out that it has no effect, and it has some negative effect from drug users who are jailed and get infected in the jail system and so on. So now we have increasing police that would love to work with health sector. So my point here, don't ignore police. There are many good police, believe me. I don't know, some of you may married to a good police and quite agree on that. So we just discussed in this country about how to integrate drug treatment and harm reduction service together, because our policy now changed to be decriminalization. That means drug users tend to not being punished by criminalize them, may punish them with another various means, and tend to try to divert them to the health and social services. It just begins. So through this reform, our idea to integrate drug treatment and harm reduction services together would be trying to use the existing treatment cascade, which recruit, test, treat, and retain, and try to fit them into the nature of addiction problems, and try to utilize the evidence-based program or studies that suggest that as long as you can keep or retain them into the system, it will be better for recovery. And if you can retain them long enough, it will increase the chance of recovery. And we know that treatment works and people do recovery. We have so many examples and evidence. So then our working group rearranged this cascade and add the word recovery into this one. So hopefully, if the policy body agree, Thailand would use this model to deliver the service, both treatment and harm reduction service for drug users in our country. So that means you can see that we include law enforcement into our outreach recruiter actually. That means we need to have a program for the police, allow them to understand what would be the pros and cons, and then engage them into the service and learn along. We do have some examples that occur already in this country, and we want to scale that up. So that's new to Thailand, but I think some other countries probably thinking along and have done some of these components of the model already. I hope this can be expanded and we can look after people who inject drugs better, and we can reach our target of 90. So client center, meaningful participation, that means we improve the self-efficacy of a drug user when they engage in the service, and they are able to provide self-care and informal care better and better. We use biopsychosocial framework, which is a new approach, trying to reduce punitive approach toward more humane approach. So to deliver the service, I think we learn a lot about the social networking and local context. Drug use in Bangkok is different from drug use in Chiang Mai and different from drug use in northeastern area in Thailand. I can show you the evidence. So you have to understand the social networking of drug user in each area. And then if you have peer worker who happy to work with, and you have mechanism to work with them, peer outreach worker and drop-in center would be the best way to start up. And yes, if you deliver the service that directly respond to their needs, they will come. And the successful would be how long you can engage them into the service. So the target 90. So ozone haven't been able to achieve close to that yet. We're still far from that. We estimated that in Thailand we probably have about 40 to 70,000 injecting drug users. Ozone gets support from Global Fund to cover only 9 provinces so far, but they are able to get access to about 10,000 people who inject drugs around the country. And we are scaling up from 9 provinces to 37 provinces and beyond the previous area. That means we need to learn more about the new context, new area, and new problem. And by doing so, we have to also provide comprehensive care package by also scaling up. So it's still very challenging and difficult to scale that up. But now we have a good policy reform. We have better understanding about the policy body on harm reduction. The Ministry of Public Health now announced a new policy that promote also drug treatment and harm reduction at the primary care level. So that's become a new challenge to Thailand. This is an example of how Thai facing drug situation differently in different areas. So you can see that in Bangkok, majority inject heroin, but some inject methamphetamine and ice. In central area, they inject less. In northeast area, they inject more methamphetamine tablet. And in northern area, we inject both heroin and opium. In the south, they inject purely heroin. So your service to provide to drug user actually cannot be just one service for all the country. You need to get to the area, understand the local context, understand the social networking. What way that ozone deliver the service in Bangkok probably cannot do that effectively in northeastern area, because the pier that they use in Bangkok is the heroin injector pier, while in northeastern area they need to find different social networking and find a new way of approaching and so on, which is they are doing at the moment. And here are those comprehensive package that agree upon by UNODC, UNH, and WHO. Needle and syringe exchange program can operate in just small area in Thailand because of the political environment is not quite that yet. So we're still struggling on this. But the others, like drug dependence treatment program, is scaling up and then spread out to the primary care level. We are training our health worker on that. We have many more psychiatrists, many more psychologists, social workers that engage into the drug treatment program now. Obviously, HIV-NAT is there already, but STI not yet integrated quite well that yet. Condom program already there, information, education, communication through peer already there, and hepatitis C just start integrated, and tuberculosis probably already there as well. And there may be more service into the package when we develop further in future. Here's one example that operate in the mountainous area, quite similar to the northern part of Vietnam. The NGO there operate with understanding from the police there, with the community leader there, and they together can work with community and family members and drug users to engage them into methadone maintenance program. So the district hospital working closely with the health center in the area and the health volunteer in the area, and they can dispense. The people who use drug doesn't need to travel long in the mountainous area to the hospital. They can get methadone near their home by community leader who are trained by the hospital and with assistance from health volunteer and health center. So the number of clients and maintenance program at community increasing through this service delivery.
We have one more minute.
Yeah, just the last slide. So for methamphetamine user, I know that in this region, methamphetamine use in increasing. Many methadone clinics in this region actually find that their clients also use methamphetamine and still struggling on the way how to handle that. We don't have a medical treatment like methadone for methamphetamine user yet. So we rely mostly on the psychosocial care. So methadone clinic that face this problem may need to strengthen their psychosocial clinic, their psychosocial care. In Thailand, because we moved that down to primary care level, we are going to utilize the new primary care system in Thailand. We call district health system that try to work with the other partners in the communities, like justice volunteer, NGO, police, social workers in the community, by using a new mechanism we call district health board as a main mechanism to coordinate this work in the community. and integrate both drug treatment and harm reduction service together under this umbrella. So it's still early. We do have some area that successfully developed this and help their clients in the community to be in the community effectively and recover. But we need a proper way to scale up. So that's maybe some way that we can learn how to deliver the service to both drug user and the other in the community. Thank you very much.
Thank you very much ค่ะอาจารย์อภินันท์